We can start the class, sir.
Okay, thank you. Hi everyone, and welcome to this the session on the Thorax part on the anatomy subject. I'm Dr. Ankit, your anatomy faculty in our Auricle platform, and let's start the session. So this is the second session on Thorax. Just a second. Right. And today we are going to discuss some other important points on the thorax. Just give me a second, guys. Yeah. No, it is fine. Okay. So yes, welcome to this 21 days course. Today being 27 December. Thorax part 2 is the discussion that we're going to discuss today. And the important points over here, you can take a screenshot of this particular slide. You can see the important topics, the coronary arteries, the heart over here, the pericardium, the thorax venous drainage, the cardiac plexus, mediastinum, and all these topics that we are going to discuss today, including the topic which I said yesterday that we are going to continue today was our thoracoabdominal diaphragm. Okay, these are topics. Why to choose Auricle, guys? These are n number of reasons over here. You can see a lot of this foundation classes that is recorded, the live classes over here, the rapid exam module over here, doubt clearing sessions, hard notes, hard copy notes, and you have a QBank also. Plus, also we have the practical sessions, and these are all the subscription plans that you can see. And here we have right from 3 months time period to 6 months to around 12 months to around 4 years. And these are all the packages written over here. In the last two plans, you get an extra hard copy note set plus one-to-one doubt clearing sessions as well. And if you want some more discounts, you can use this code below, that is Dr. Ankit 20 to avail some extra discounts. Okay, let's move forward to the session and let's see what we have in store for us today. Okay, so here we go. Just a second. Yeah. So it's a thorax part 2 over here. And yesterday we discussed few topics from the thorax. If I just recall what we discussed yesterday, it was basically about the thoracic wall, including the thoracic cages, plus obviously the intercostal spaces, and also about a bit of the pleura. Okay, and let us see what we're going to continue from there. So as already told you guys, the coronary artery disease, that is obviously the heart attacks, the angina pectoris, the myocardial infarction, all that is related to this blood supply of the heart. So that we'll see today. Plus obviously the outline arrangement of the heart and the heart walls, and about a bit of the pericardium and including the pericarditis, and also about the venous drainage of the thorax. So yesterday we discussed about a bit it, and today we'll just carry on from here. And also I'll give you insight of the azygous venous system. Okay. Then we have the cardiac plexus, and very important topic as the mediastinum, and this is azygous venous system. Let's begin with the azygous venous system, and then we'll continue to other parts. So as we were discussing yesterday, guys, in the previous session, that we have a intercostal spaces, right? Both anteriorly and posteriorly. Anteriorly, if I recall how many spaces we had, if you're thinking 9, correct, and posteriorly we had how many spaces? 11 spaces. In both the anterior posterior spaces, we have arteries and veins. We have arteries and veins. Arteries we discussed yesterday. Regarding the veins lying on the anterior intercostal spaces, that is the anterior intercostal veins, these anterior intercostal veins, they ultimately go to the internal thoracic vein, and from there, okay, they will go to their respective brachiocephalic veins and ultimately into the SVC and all. So that is pretty much direct the return of the circulation as well as the anterior intercostal artery. But if we talk about the posterior intercostal artery, they were basically coming from the descending thoracic aorta, the maximum of it. Now, but these veins over here, that is the posterior intercostal veins, they drain to a spatial system of veins known as azygous venous system. That is what we are going to see now. Okay, so here you can see the 2 and the 1 posterior intercostal veins. And these posterior intercostal veins, which are ultimately directly or indirectly draining into azygous system. What is azygous system? What does this term actually mean? So if a question comes regarding the azygous system, you have to start with that the zygous system of veins lies in the posterior aspect of the thoracic cavity. Number 1 point. Second point, it's an unpaired. Unpaired meaning by it, a zygous vein is singular. It's only on one side. Other side, we will see we have a hemizygous veins. And the third and most important point regarding the introduction of the zygous vein is that it connects SVC to IVC or vice versa. So it is SVC to IVC or IVC to SVC. Okay, so what's so much important in this connection? The important point in this connection is that if tomorrow in that particular human body, there is an obstruction to either SVC or IVC, the blood is shunted via the azygous vein ultimately to either the SVC or IVC, depending on where the obstruction is, ultimately to the right atrium of the heart. So that the blood circulation remains constant, remains patent, no matter if the SVC or IVC gets compressed or obstructed. That is the relevance of it. Now here you're seeing the right-sided and the left-sided over here. Okay, just let us see the theory, then I'll show you an image as well. On the right side and the left side, the beginning over here, let me use a highlighter over here. The beginning, that is the first intercostal veins, the first posterior intercostal vein on both sides. They go into the respective brachiocephalic veins. First ones. Why? Because first ones are quite higher up. Then on the right and left side, the right side and the left side, the second, third, fourth spaces, they will have their own posterior intercostal veins. They will form their own superior intercostal vein. They will form their own superior intercostal vein. What actually happens is that on the right side, this right superior intercostal vein, which is draining the right, second, third, fourth space. If I show you the diagram over here, the first part is clear. The second part, on the right side, the second, third, fourth intercostal, which are forming this, they will drain into azygous vein. Here you can see this, it is draining into the azygous vein over here. This is the azygous vein. This over here is AV, that is azygous vein. So on the right side, they are draining into A dot V, azygous vein. But on the left side, the second, third, fourth intercostal veins, posterior intercostal veins, they again go where? They'll form the superior intercostal, but they will go to the brachiocephalic vein on the left side. Let us see in this diagram. This left superior intercostal vein, which is second, third, and fourth, it drains into brachiocephalic vein. That is a minor difference. So if we recall it, the top ones, the first ones on both the side, they drain into brachiocephalic vein. The second, third, fourth on the left side again will drain into brachiocephalic vein. So these three group of veins, the right, left first, and the left second, third, fourth, they go to brachiocephalic vein. The rest all, the right, second, third, fourth, and fifth to 11th on both the side, they directly or indirectly, they will drain to azygous vein. Now you might see in this particular slide that they are showing accessory hemizygous and hemizygous on the left side. But what actually happens is both this accessory and hemizygous vein, they also drain into azygous vein. Can you see it in a diagram? Here we can see all of it. How? Let me use a bit of highlighter over here. And yes, here you are seeing the hemizygous vein and the accessory hemizygous vein. This point over here, if I'm using highlighter, and I hope you can see, the blood is going from left to right side and draining into azygous vein. So below 5th to 11th on both the sides, they drain into azygous vein directly. On the right side, the right superior intercostal, that also drains into azygous vein. The rest, if I may highlight the light green color over here, the left superior intercostal, and we have the left, the beginning one, that is the right and left first posterior intercostal. Okay, just a second. I was to use the green color. Let me use it again. Yeah, the left superior intercostal, that is the left second, third, fourth, and the right and left first posterior intercostal. This green highlighted, they drain into brachiocephalic veins. And the yellow highlighted, they drain into azygous veins. The basic difference is not much. Why? In a normal subject, in a normal person, they all will drain into SVC only. Because the entire azygous vein or the brachiocephalic vein, they drain their blood into SVC, which ultimately goes into the right atrium of the heart. So remember this, and remember this basic point, that It's an unpaired system of vein because it is only on one side. And it actually joins or correlates or it makes a collateral between the superior and the inferior vena cava. Important point is this. And this diagram, you should try to make it. Please, I request all of you to practice this image, not only for your university exams, but also later on, once you will go through the medicine and the surgery and other subjects, plus even the PG exams, the NEET PGs or the next PGs. This topic is one of the most commonly asked topic from the thorax, the azygos venous system. Remember that. Okay, here is an image showing us the azygos vein over here. So this is the azygos vein, and it drains into which vein? Above, it is going into SVC under normal conditions, and below, if you see, then it is formed or it is communicating below with the IVC. So normally the blood is going in this direction. But if there is an obstruction to the SVC, the blood will go in this direction. So that's very helpful. And where does it lie? It lies in the posterior aspect of the thoracic cavity or the thoracic cage. Why? Because it is draining the posterior intercostal veins. Therefore, it lies posteriorly. Okay, point clear? Okay, let's see then the topic. And here we have the diaphragm over here. Here is the diaphragm over here. So what is the diaphragm? Diaphragm is actually diaphragm. We call it as a thoracoabdominal diaphragm. It's a culmination or it's a junction of many different types of muscle fibers which form actually the diaphragm. It's a culmination of many different types of muscle fibers. It's a dome shaped over here. It's a dome shaped. It is like this. It's a dome shaped if you look at from the straight forward. And it forms a partition between the thorax and abdomen. It's a musculoepineuritic, mainly muscles over here. The difference between the diaphragm and any other typical muscle is, understand that also, is that in other muscles, what happens is, say any normal muscle, say biceps. In the center, we have a muscle belly, agreed? In the center, we have a thick muscle belly. Take any skeletal muscle in that case. And on the sides, we have this tendon, which attaches this muscle to any bone. That is a normal thing. In case of diaphragm, the tendon lies somewhere in the middle. Therefore, that tendon is known as a central tendon. While the muscles, they are spread out on the peripheral side. Muscles are spread out over here. So that is the difference that we need to address over here. That in the diaphragm, we have a tendon that is lying centrally. So we call it as central tendon. Well, the entire periphery of the diaphragm, here we have in the diaphragm, here the muscles over here. They'll come through different parts that we'll see. So peripheral part is muscular and the central part is tendinous. Is this point clear? Remember, it forms a partition. Now, why do we need diaphragm? Understand, this is basically, it is not just meant to separate thorax from abdomen. It's separate as if there are two liquid spaces that are being separated. No. The thorax has its lungs and abdomen, the lungs and the heart. The abdomen has its liver and the other gut structures. Why we need a partition? We basically need a partition so that whenever we inhale deeply, the diaphragm will contract and will move down. So whenever the diaphragm contracts, it moves down. So when it moves down, what happens is the space over here enlarges, and that helps in inhalation or basically indirectly in our respiration. So basically the diaphragm is a respiratory muscle, is an inspiratory muscle of the respiration. So when you inhale deeply, the diaphragm, which is a dome shaped, it flattens out, which is a dome shaped, it will flatten out so that the thoracic cavity volume increases. Okay, the volume of the thoracic cavity increases because the air is being inhaled inside. That is what the main role of diaphragm is. So it is attached, peripherally it is attached to which structures? Peripherally, all this muscle part, as we are saying over here, that is attached to what? It is attached to the lower part of thoracic cage. So peripherally, this part is attached to the lower aspect of thoracic, what? Thoracic cage. Thoracic cage over here. What is there in thoracic cage? The ribs, the lower ribs. Behind we have the vertebrae. Anterior we have the lower part of sternum xiphoid. So with your common sense only, you know that, okay, diaphragm muscles over here attached to which part of the bony structure? The lower ribs, the lower vertebrae, and the lower part of the sternum. Simple as that. Okay, let us see more an image over here. Now in this image, if I put again a highlighter with the blue color highlighter over here, this is the central tendon area. What is this? This is a central tendon area. Okay, agreed? This is a central tendon area with a opening, with a major opening over here, that is vena cava opening. Now which vena cava will pass through it? SVC or IVC? Lower part. So here we have the IVC. Here we have the IVC. So we have a central tendon. Now regarding the peripheral part, we all know that this all is muscular part. This all is what? This all is muscular part. Okay, let me just 1 second try to highlight most of it. This green highlighted area over here, this is the peripheral muscular part. Now, as we just discussed, that this peripheral muscular part will attach to the lower part of thoracic cage. So what are these numbers referring to? 7, 8, 9, 10, 11, 12. The lower 5 or 6 ribs. Okay. And tail, if you look over here, we have the xiphisternum, not the manubrium, but the xiphisternum anteriorly. And if we go posteriorly, then can you see these two projections down? They are known as the right and left crus of diaphragm. They are known as right and left crus of diaphragm, and they are attached where? They are attached to the vertebrae behind. Now you might argue, okay, sir, vertebrae means T12 vertebrae. No. Here we have a bit below T12 vertebrae. So the right crus goes from L1, L2, and a bit of L3 as well. And the left crus of diaphragm over here goes to L1, L2 vertebrae. So these are all the peripheral attachments of diaphragm. One opening we have seen, we have a vena cava opening, that is the inferior vena cava, where through the central tendon of diaphragm. And let me ask you guys, the superior or the inferior vena cava, they open into which chamber of the heart? You also said that's a very easy question. They open into right atrium. Very good. They definitely open over here. This right atrium, will it be on the right side or the left side? Sir, should be on the right side. Even if you don't know the entire anatomy of the heart, you can even argue that it should be on the right side. Therefore, if you look at the vena cava opening over here, this is lying towards the right of midline. Okay, 1 point. Now this is one of the major opening, number one. The other two major openings are the aortic opening over here and the esophageal opening over here. Number 2 and 3. And number 2, if we can see the aortic opening, number 3 is the esophageal opening. Number 3 esophageal opening, we can highlight with the green color just to show us that this esophageal opening is passing through the muscle part of the diaphragm. And esophagus opens into the stomach. Stomach normally is on which side? Right or left? Right, we have liver. Stomach is on the left side. So you can see the esophageal opening is towards the left side of the midline. And as you go on to the and the final opening, that is the aortic opening. The aortic opening is not through the muscle part of the diaphragm. So we are giving it, say, a yellow color over here. It passes between the two crus of diaphragm over here. Here we have the two crus, the right and the left crus. So it is quite posteriorly, as you can understand, the aorta. And it is basically between the two posterior attachments of the diaphragm, the aortic opening. These are the three major openings must know. And also questions have come that these major openings, they are at which vertebral level? Which vertebral level? So there's a mnemonic, or you can just remember it that this is at T8 level, this is at a T10 level, and this aortic opening is at T12 level. So how to remember the mnemonic is? The mnemonic over here, let me write, and let me choose a different color over here. The mnemonic for the major openings is I ate. 8 means I ate something. Okay, I ate 10 eggs. Okay, at 12. 12 means some time 12. So 8 over here is 8 number. I over here is IVC. So IVC opening is at which number? 8, T8. 10x. So 10 is T10, X, E for esophagus. At 12, A over here is aortic opening. A over here is aortic opening. And 12 is T12 level. So I ate 10x at 12. You can remember it. These are the three major openings. Apart from these three major openings, if I may use another highlighter over here just to demonstrate you some of the other openings, you will see that we have a few of the arcuate ligaments over here. There is a medial and a lateral arcuate ligament, and there are these two crus of diaphragm. Plus anteriorly, if you see, you have a space between the sternum and the ribs. From these spaces, we have like sympathetic trunk going down, we have subcostal vessels going, we have the superior epigastric vessels coming out. Okay, we have the splanchnic nerves coming down. So these are all known as what? These are all known as minor openings. So just remember, in case of diaphragm, always do remember there will be definitely, you have to write it, major openings and minor openings. For major openings, 3, IVC opening, esophageal opening, and aortic opening. For minor openings, we have behind the arcuate ligaments, some structures passing through the crus of diaphragm, and anteriorly also that is known as Morgagni space or Morgagni area. Anteriorly, where we saw that epigastric vessels over here. That's enough. So remember again, the diaphragm forms a musculoepineuritic partition between the above-lying thorax and the lower-lying abdomen. Peripherally, we have the muscles. Central, we have the tendon. And these are the other openings. Let us see some other images. Another schematic or image for the diaphragm with an anterior view. This is an anterior view over here. You can see the IVC over here to the right of midline. You can see the esophagus over here to the left of midline, and somewhere posteriorly we have this aorta over here. Here we have the descending aorta. Now this descending aorta over here is now coming down into the abdomen, so we can call it as descending abdominal aorta once it passes through the diaphragm. And what are these two? These two structures over here, if you can see, these two are what? These two are crus of diaphragm. So you can see the right crus is a bit below, it reaches till L3, L2, L1 over here, and the left one passes somewhere between L1 and L2. Okay, let me show you other things over here in the anterior view. What is this thing over here? This is the upper end of the psoas major muscle known as medial arcuate ligament. This is the medial arcuate ligament over here. And this structure lying lateral to it, this will be known as the lateral arcuate ligament over here. And between the two medial arcuate ligament is the median arcuate ligament over here, through which the aorta is actually passing. Okay, so this is a frontal view. Now, some of you might get confused that, sir, but sir, we thought diaphragm is like this. How in the front we are seeing it like this? Why? Because understand, anteriorly, what is the attachment of diaphragm? It is a xiphoid process. Now, if I ask you, xiphoid process is at which vertebral level? Yesterday we discussed. Sir, yes, sir. I recall it was T9. Very good. And behind you are seeing that it is going below T12. That is still L1, L2, L3. This is if imagine the anterior, we have the T9 attachment. Then what about T10, T11? So T10, T11 will be over here. T9 will be over here. So if you see like this, then the diaphragm may look a bit vertical. And if you look at anterior view, it may look a bit vertical. And if you're looking from above or below, it is a partition. So imagine it to be a 3D image. Okay. Diaphragm here. This is anterior side and that is the posterior side. This image, I guess all your confusions, if there is any, will be cleared. This dark colored line with the arrows over here is representing the diaphragm. So this is the anterior attachment diaphragm over here, the xiphoid process, and behind it is going below T12 into L1, L2, L3. IVC opening over here is at which level? 8 IVC. Esophagus you can see coming down, passes through T10, esophagus. And then aorta passes around T12, that is the aortic opening. Okay. So if you are looking at an anterior view, the diaphragm will appear somewhat like this, as you can see in this image also, anteriorly. But if you look at from a superior aspect or you look at from an inferior aspect, it looks like a partition. Okay, fair enough. Minor openings, as I already told you, we have a Larry space also, that is known as the anterior space, the Morgagni space, also known as Larry when openings enlarge, known as foramen of Morgagni. So in Larry space, when they get enlarged, we call it as Morgagni. Anteriorly where? Between the sternal origin, that is a xiphoid, and the 7th costal cartilage. So minor opening number 1 over here. Number 2 is that between the 7th and 8th, we have the musculophrenic vessels, the vessels supplying the anterior intercostal arteries. And between the costal margin of diaphragm and transverse abdominis, we have the lower 5 intercostal nerves. Now, why lower 5? Lower 5 meaning by we have from T7, T8, T9, T10, T11, and also T12. Because these are T7 to T12, they actually go below and they supply the abdominal wall. So these thoracic nerves, they not only supply the thoracic wall, they will also supply the abdominal wall. So minor openings over here and other minor, this is all you have to write in your theory. Behind lateral arcuate ligament, subcostal behind middle, sympathetic, and then crus over here is discussed, and cupula is where you have that on the left side opening, opening made with the placement of the heart over here, the left phrenic nerve. Okay, minor openings, nerve supply over here, do remember it, the sensory nerve supply and the motor nerve supply. Always do remember that the motor nerve supply is entirely from which nerve? It is entirely from the phrenic nerve, no other nerve. So if the phrenic nerve, which has the root value of what? C3, C4, C5. So if the phrenic nerve, which is coming from the neck region, if it gets damaged any way through its entire course, the diaphragm is paralyzed. Because the only motor supply is phrenic nerve. Well, if you talk of sensory nerve, then the central part is phrenic nerve. The lateral parts are supplied by the intercostal nerves. Because from the lateral part, we have actually the lower 6 ribs. So when we have the lower 6 ribs, as we already discussed, we have the intercostal nerves, and therefore the lower 6 intercostal nerves, T7 to T12, they will supply the sensory to the lateral part of the diaphragm. But motor supply, do remember, the motor supply is through the phrenic nerve only, which is the root value of C3, C4, C5. Okay. Here you are seeing an image over here. Blood supply, yes, you can just read it once or twice. Whatever blood vessels are passing through it. And most of these blood vessels will have their names phrenic along with them. Phrenic. So whatever artery you can remember. Musculophrenic, pericardiophrenix, superior phrenic, inferior phrenic. Phrenic means diaphragm. Okay. And one additional add you can ever hear the intercostal arteries. Applied anatomy, there can be 2 hernias. Do remember their names. Again, they will come when you will study the pediatrics later on. The Morgagni hernia and the Bogdalex hernia. Remember, the Bogdalex hernia is much more common than the Morgagni hernia. And they are basically meant for congenital diaphragmatic hernia. What is congenital diaphragmatic hernia? That when a child is born with a hernia through the diaphragm, the child is born with that pathological condition. The diaphragm is not totally developed. So there is some abdominal cavity viscera that goes into the thoracic cavity. That is known as congenital diaphragmatic hernia. And 2 are very common over here. Out of these 2, Bogdalex is much more commoner than Morgagni hernia. Morgagni is more on the anterior aspect. Bogdalex is more on the posterior aspect of the newborn diaphragm. Okay. Okay, here we have this. This just to show you some of hernias over here. You can see the hernia. This is the diaphragm. Understand that this is the diaphragm over here. This is the diaphragm over here. You can see the esophagus and the stomach. And when it comes out through it, that is our hernia. So it can be a hiatal hernia, or also known as sliding of the hiatal hernia when the entire upper part of the stomach slides, or it can be a rolling or a paraesophageal hernia. It can be a rolling or a paraesophageal hernia. The paraesophageal means the esophagus remains at its location, but parallel to it, some part of the stomach protrudes into the thoracic cavity. So what is the big deal? Suppose there is hernia. This hernia or congenital diaphragmatic hernia, what is the issue? The issue over here in all these hernias is, in all these diaphragmatic hernias is that the abdominal viscera, which is huge, we have a long intestine, it takes up the space of thoracic cavity. Now, when it is congenital, the problem is a bit different. What is the problem? The problem is that if during development of the child, the abdominal viscera is coming into thoracic cavity, it will give less space for the development of lungs. In those cases, there is hypoplasia of lungs. The lungs are not developed what they should have developed. There is immaturity in the development of lungs. And that refers to hypoxia and could lead to different respiratory conditions in a neonatal. Neonatal means the initial 1 month of the birth. That is a problem. And mostly it can come as a MCQ question that what is the most common cause of death in case of congenital diaphragmatic hernias. The most common cause of death is the hypoplasia of the lungs because lungs have not yet developed. Child is born, lungs are not fully developed. Obviously, create some problems. Okay. Okay, this was about the diaphragm. Do remember it. It can come as a question. Try to make these diagrams. This is a very simple diagram, but try to make this practice. This one. Okay, numbering on the side 7 to 12. Make minor major openings. At least make major openings, and show what is passing through them. It is see. Other cases can also see. Let me just add an information over here that when you are talking of the IVC opening, only IVC passes. No, along with it, the what actually passes through the right phrenic nerve will also pass. Okay. Along with esophageal opening, along with esophagus, what else passes? Along with esophagus, the vagus nerve pass, and also esophageal branches of left gastric artery that will also pass. Along with aortic opening, is it only the aorta that passes? No, along with aorta, what else passes is the thoracic duct and the azygous vein. The azygous vein, I hope you remember. So remember these points. Look at diaphragm. Next, we come after diaphragm to mediastinum. Mediastinum is what? It is space between the right and left pleural sacs. Pleural sacs means pleural spaces. This topic, mediastinum, is more of an understanding. I mean, it will obviously can come in the exam, no doubt about it. But you have to understand this. If you understood this, clear. So let us start. Here you are seeing at a thoracic cavity with all the anterior rib cage that is removed. Now, what you're seeing over here, this all part over here, these all are lungs. Yes or no? This all is lungs. So the majority of the thoracic cavity, 70-80% of the thoracic cavity is actually filled up by lungs. So if you just imagine that you remove the lungs, whatever else is left, all these spaces having the vessels, the thymus, the trachea, the heart, the pericardium, the esophagus, all of this, these all come under the topic of what? They all come under the topic of mediastinum. Simple as that. So mediastinum, technically, or for understanding purposes, is actually the thoracic cavity minus the space occupied by lungs and pleura, lungs or pleura. Whatever is left comes under thoracic cavity. Now comes under the mediastinum. Mediastinum is the entire thoracic cavity. Thoracic cavity is a volume. So the entire volume of thoracic cavity minus the volume that is taken up by the lungs and pleura. So you might think that, sir, does it mean that the heart will also be a part of mediastinum? Absolutely, yes. Heart is a part of mediastinum. Not just heart, the vessels. Think about the structure, the esophagus, the aorta, right? And many structures that you'll see, they are all a part of mediastinum. And mediastinum, understand that this heart is in a living body, it's pumping blood. And there are veins and arteries also coming out of it. So this mediastinum is not a static area, it's quite a dynamic and quite a mobile area, because the heartbeat rate is somewhere between 70 to 80 per minute. Normal cases can go till 100 and more than that. 70-80 beats per minute, that is more than 1 beat per second. More than 1 beat per second. So you can understand the movement in the mediastinum, because heart is a part of mediastinum. Okay. Now, an image over here. This is again a lateral view, as you might be quite familiar by now that this image, we have an anterior and the posterior structures. This is the sternum, this is the manubrium of the sternum, and that is the body of the sternum, BODY. Let me write over here, and below X over here for xiphoid process. Behind you have the numbering over here. These are the thoracic vertebrae over here. Now this entire mediastinum is divided by this imaginary plane, if I may mark it like this, that passes through the sternal angle. Sternal angle, I hope you are very clear that this part is a sternal angle that passes between the vertebrae T4, T5 disc over here. So we have this imaginary plane which divides the entire mediastinum into superior and inferior, superior and inferior. So this S over here refers to superior mediastinum. So this all is superior mediastinum. and remaining below, that all is inferior mediastinum. But in inferior mediastinum, you might be looking at AMP. What is AMP? Just a second. AMP is this over here. A, M, and P. That is anterior, middle, posterior. That is anterior, middle, posterior. So what actually happens is that this inferior mediastinum is divided into anterior mediastinum, middle mediastinum, and posterior mediastinum. Okay, sir, but how to remember it? Simple. Simple is that this middle mediastinum over here, it includes the pericardium and the heart. Pericardium and the heart. So whatever space is in front of the heart is anterior, which is a very, very small, narrow space. And the space behind the heart is posterior mediastinum, which basically contains esophagus and descending thoracic aorta, mainly. That's it. So below the imaginary plane through the sternal angle, we have the pericardium and the heart that forms the middle mediastinum. In front of it, a very narrow space, anterior, and behind it, we have a posterior mediastinum. All this anterior, middle, posterior, they are a part of I for inferior mediastinum. And above the plane, we have the superior mediastinum. Superior mediastinum. This distinction is clear. Now we just have to understand that what are the major structures lying in these mediastinum. If you got a good hold of it, good to go. Just let me tell you a few things over here. Let me use a highlighter just to show you the aorta. Just imagine the ascending aorta, the arch, and the descending thoracic aorta. Yes or no? Goes like this. So the arch of aorta is lying in the superior and the descending lying in the posterior mediastinum. Okay, let us see more. Let us see the trachea. Okay, so the larynx follows down as the trachea. Trachea divides over into two bronchi. Let us see the esophagus, just for understanding. Esophagus comes as a inferior continuation of the pharynx, and the esophagus will go down like this, and that will pierce the diaphragm and go down like this. Hey, yes or no? And then also you can see at the various vessels, the vena cava, the superior vena cava, and the inferior vena cava. And along with the superior vena cava, you have the brachiocephalic veins and other veins over here. Along with the arch of aorta over here, you know that you have the brachiocephalic trunk, the carotids, and the subclavian arteries. Just to give you some idea. Now, if you look at each mediastinum separately, the superior mediastinum, if the question comes regarding the superior mediastinum, first of all, start the boundaries. So what lies above is the thoracic inlet over here. Just see, you don't have to cram everything. Try to make a diagram, things will be clear. This is the superior boundary of the superior mediastinum. This lies anteriorly, so manubrium sterni. This lies below is the imaginary plane over here. And posteriorly, we have the upper four thoracic vertebrae with their disc and the ligaments over here. This over here is the superior mediastinum. If we just use a bit of highlighter over here, this entire is a superior mediastinum. I hope you all will agree over here that this is our superior mediastinum. Agreed? Simple as that. Okay, this is superior mediastinum. Now, what lies in superior mediastinum? Contents. Contents, we have retrosternal structures, that is just behind the sternum. And then we have intermediate structures. And then we have a prevertebral. What does it mean? It means that it's a very big space, superior mediastinum. So what we have done is we have divided this into a retrosternal structure, prevertebral in front of vertebrae, and the intermediate structure. Just like we had divided the inferior into anterior, middle, posterior, for the content basis, we have divided into it. So retrosternal structures. Now don't cram, just read it 2-3 times, and things will be very much clear. So we have some muscles, sternothyroid, sternohyoid. They go to the thyroid and the hyoid bone in the neck. So they are going above. Then we have thymus, we have veins, we have the veins from the vena cava, and these are so behind the sternum is basically a few of the strap muscles. Okay, and mainly there are veins. So just behind, if you open up the manubrium sterni, just imagine. See, keep on imagining. Suppose tomorrow you are doing a surgery or you're standing in an OT. What lies just behind the sternum are basically the major veins. The brachiocephalic veins are forming the SVC. Then if you look at just behind those major veins, you basically have the arch of aorta with its branches, thick branches over there. Then obviously you have these nerves which are around these artery branches. So if you remove the sternum, first you will encounter the venous or the veins. And if you retract the veins, behind the veins, you will see the arch of aorta and its branches. And if you retract those arch of aorta and its branches, then you will start to see what? You start to see mainly main structures, the trachea. Then you're going to see the esophagus. Then you're going to see the thoracic duct. And along with that, you will have some lymph nodes, you will have some nerves that you can see. We'll show you an image also, but just understand. So we have the veins in the beginning. Behind it, you have the arteries. Then behind it, you have the trachea, esophagus, and relevant structures. Okay, now have a look at this image. This image is a transverse section from the superior mediastinum, the anterior part over here, and the posterior part over here. Now, if I just highlight few structures so that you can practice this diagram, it's not a very difficult one. See, anteriorly, what we have these muscles, but most importantly, we have the brachiocephalic veins and the vena cava over here. These are retrosternal. Then intermediate was were which structures? The branches of the aorta. Along with them, some of the nerves over here. Then prevertebral, that is in front of vertebrae, we have the esophagus and the trachea, and relevant some thoracic duct and other structures. Simple as that. Just imagine in front we have this sternum. This is which part of the sternum? This is manubrium sternum, because we are talking of the superior mediastinum. So that superior mediastinum, it is actually where it is actually above the sternal angle. So this sternum is actually our manubrium sterni. And the point is clear. Revise it again and again, things will be clear. Here is an image showing us the same similar things, but an anterior view showing us first of all we will have the veins over here, and behind the veins this purplish is the arch of aorta, and then we have the trachea and the esophagus. Just remember this anatomical correlation or relation between the structures. Trachea is what you can feel over here, trachea, the tracheal rings. Then inferior mediastinum, we have seen that is divided into anterior, middle, posterior, that we already have seen. What will be there in the anterior mediastinum? Very few structures. Mainly is this, that sternopericardial ligament. What is this? Here we have some ligaments anteriorly, which are actually connecting what? The sternum to the pericardium. So here we will have some ligaments which are connecting sternum to the pericardium. They are known as sternopericardial ligaments. Some tissue, some lymph nodes. Middle mediastinum is what we had the heart, but there will not only be heart. This is obviously going to the pericardium, and then understand heart. When we say heart, no, then there are various structures or vessels which are coming into heart and going out of heart. All of them are joined to the heart. So therefore, you will see ascending aorta, pulmonary veins, pulmonary arteries, superior vena cava, azygos vein. All these structures are connected to the heart only. That completes the 5-6 points. Okay, and then in the middle mediastinum, just behind the heart, what we also have, we have the trachea bifurcating into the two bronchi and some nerves and vessels over here. They also supply the pericardium. So lower part of the trachea, along with its bifurcation, it lies very close to the heart. So we include it in the middle mediastinum. They are not going into the heart, but they are very close to the upper margin of heart. So we include them into the middle mediastinum. Okay, then what is left is the posterior mediastinum, that is behind the pericardium. It is quite long. It is not very big space, but it is quite long space. It's quite long space. Boundary is above, posteriorly below. So above we will have what? That imaginary plane. Below we will have the diaphragm. And behind we will have the vertebrae and their disc and ligaments. So what is posterior mediastinum? The space in the inferior mediastinum behind the pericardium. Okay, here's one more image with a different color coding. This is a very good image. The blue color is representing which mediastinum? If you're thinking superior, very good. The yellow color represents the anterior. I'm writing over here yellow. The red color, the middle. And the green color representing the posterior mediastinum. I hope it is clear. So you can see the green area is quite long. The main two contents, main, are esophagus and aorta. The main two contents in posterior mediastinum are esophagus and aorta. But if you go back to our topic of the diaphragm, we said along with esophagus passes vagus nerve and also esophageal branches of left gastric artery. Along with aorta passes the thoracic duct and azygous vein. So these again will be a part of posterior mediastinum. Let us see over here contents of posterior esophagus, aorta. But along with that, thoracic duct, azygous vein, its venous system, vagus nerve along with the esophagus, splanchnic nerves, lymph node and vessels. Again, see, we can correlate the knowledge. With the diagram, we only know, okay, there is esophagus and aorta. There is the esophagus going down, that is the aorta going down over here. But we know what other structures can pass along with the esophagus and aorta. They will also be a part of the posterior mediastinum. Okay. Transfer section to the posterior mediastinum again through the 8th vertebrae. Here again, we are seeing the aorta mainly over here. And after this aorta, we can also see the hemizygous and the azygous ducts over here. Okay. Right. Just a second. Okay. Right. I hope the mediastinum part is clear. Now, applied anatomy, that in the again the theory part you can write. Talk of the mediastinal syndrome. Now, that may look like a very big topic on the topic. Any tumor or any growth which can compress the mediastinal structures will give rise to a group of symptoms. Why? Because understand that that space is very congested. It's a very narrow space. The mediastinal space is very narrow space. Getting a point? And therefore, any growth over there will compress the structure that we just saw. Like if it compresses the esophagus, there will be problem in swallowing, dysphagia. If it compresses the trachea, there will be problem in inhaling, dyspnea, shortness of breath. If it compresses the recurrent laryngeal nerve that supplies the larynx, and larynx is the voice box, then there will be hoarseness of voice. If the tumor or the growth compresses the phrenic nerve, as we just saw, it is the sole motor supply of diaphragm, there will be paralysis of the diaphragm. There can be also compression of the intercostal nerves, causing intercostal neuralgia. So it comes along a common term known as mediastinal syndrome. And if a patient comes to you with all these symptoms or signs, with a plus or minus, some more, some less, and don't get confused. That's the patient saying that the patient is not able to swallow, he's even unable to breathe clearly, and his voice has changed. I know what is happening. Even there's some shortness of breath because there's paralysis of diaphragm also. Think about mediastinal syndromes. Go and ask the patient to have an X-rays or ultrasound, a CT scan of thorax to see if there's anything over there, any growth over there. Okay, so understand this clinically also. So this was about the mediastinum. So divisions of it, common sense, and what are the various structures in it. That is our mediastinum. Now let's come to another topic, that is our heart. We all have learned much about the heart. Heart is a hollow conical muscular organ. Okay, over here in today's session about the heart and its vessels, I'll just show you some of the important points. Okay, what to draw in exam, how to draw them, and what actually needs to be remembered by you. Because heart as a topic comes not only in theory, but it's a very, very common thing to be asked in your vivas, plus also in your any level of exams that you are giving later on, plus medicine, surgery, pedia, whatever further subjects you have in your other years of MBBS, heart will come. Heart we all know is very important. So it's a hollow conical muscular organ. It's present where in the middle mediastinum, just to begin with, and some dimensions over here. Remember the heart, if we draw like this anteriorly, this left lower projecting part is known as the apex of heart. Right? Above, behind this part over here will be the base of heart. So apex lies below, the base lies above. While if I talk of the lungs, okay, if I talk of the lungs over here, the right lung and the left lung, the apex of the lungs are at the top and the bases are at the bottom. Understand this. So in the heart, the things are a bit different. So if we try to draw heart over here, the apex of the heart is lying over here and the base over here is lying posteriorly over here, as you'll see. So some dimensions, apex to base is around 12 centimeter. AP diameter is only 6 centimeter. Transverse diameter is around 8 to 9 centimeter. And weight is around 250 to 300 grams, a bit more in males compared to females. Okay. Here's a simplified diagram. At least you should be able to draw this diagram, guys. Just to show the major vessels coming into the heart or going out of heart. So here we can start with the brachiocephalic veins. These are the two brachiocephalic veins that form the superior vena cava. Then you can try to draw the inferior vena cava plus the aorta, arch of aorta, and the pulmonary trunk. And finally, the four pulmonary veins. These are the pulmonary veins over here, two on the right, two on the left side, going behind into the left atrium of the heart. Basically, this should be very clear. Then, if there's a long question regarding the surface border, remember there are three surfaces and the three borders. These surfaces are anterior surfaces, inferior surfaces, and the left surface. Anterior surface is also known as sternocostal surface. Inferior surface, that is above the diaphragm, known as diaphragmatic surface. Left is left surface. Three border, right, inferior, and the left border. Okay, simple. Grooves. Grooves are actually small spaces for the passage of the coronary vessels. Understand this part. And these small spaces are between the chambers of the heart. So we have AV grooves, atrioventricular groove between the atria and ventricle, known as coronary grooves. Then we have interventricular between the RV and LV. Remember, in embryology, we have seen the development of heart. And that I told you there is dilatation, there is folding, there is septation of the developing endothelial heart tube. That septation divides the common ventricle into two ventricles, so common atria into two atria. So there is interventricular grooves and there will be interatrial grooves as well. There will be interatrial grooves as well. Okay, some of the grooves over here. Now these grooves, as I said, they are between the chambers. They are mainly meant for passage of coronary vessels, the right coronary artery or the left coronary artery. Because the chambers, most of the time, they are in constricted state. So if a vessel is running over, say, imagine the ventricle, over the ventricle, whenever the ventricle will contract, the vessel will be compressed. So therefore, the vessels, they lie between the ventricles and the atria. So that when either atria contracts or the ventricle contracts, the vessel, the coronary artery should not be compressed. So that the heart should receive its normal blood supply. Understand the common sense behind this. It's a common sense behind the anatomy of the human body. Okay, so some grooves over here, apex of the heart, some positions. You should also auscultate with the stethoscope at the apex, hearing the heart sounds. It lies in the left intercostal space, somewhat around 9 to 10 centimeters from the middle line, slightly below and medial to the left nipple. That is the location of the apex of the heart over here. You should all auscultate it in your own or in your friend's chest cavity. Auscultate this. Okay, formed only by the left ventricle. Okay, the apex is this anterior view of heart. You are seeing the apex over here, sternocostal surface. So simple basic diagrams you should make. Base or posterior surface mainly formed by left atrium. It is, so the base is lying posteriorly. So this is a posterior view of the heart. Remember, try to draw this diagram also. Don't only limit yourself to the anterior heart image, posterior heart image also. So you can see these four are pulmonary veins opening into left atrium. And this is what SVC. What is this? IVC. This is the right side. This is left side. Why, sir? Because we are looking posteriorly. Okay, so this, all of this becomes the base of the heart. So it is 2/3 by left atrium, 1/3 by right atrium. SVC, IVC, what is this? Obviously aorta. Okay, if I ask you what is this purple color structures? It is neither aorta, nor SVC, nor IVC, nor pulmonary vein. What is this? Pulmonary trunk, basically pulmonary arteries, right and left side. But sir, arteries are red in color. Okay. Think about it. Are all the arteries red in color? No, pulmonary arteries carry deoxygenated blood. They are shown over here with the purple color. Okay. Okay, so base over here. Try to draw these images. Say heart diagrams, anterior and post. There are only not many diagrams, anterior, posterior view of the heart. should be practiced, showing all the major vessels and the chambers and the grooves over here. Simple as that. Simple as that. There are two major diagrams that you should know. Why? Because these two diagrams in the heart, the anterior and posterior views, they will be used when a question comes about the coronary vessels. Again, they can be used. Remember this sternocostal surface of the heart, anterior, again anterior surface, you have these combination. Don't forget how much each chamber contribute. So it's an anterior view of the heart. This all is sternocostal surface, 2/3 by right ventricle, 1/3 by the left ventricle. Okay. Then diaphragmatic inferior surface, again left ventricle 2/3, and right ventricle 1/3 over here. So the tide has just changed. Diaphragmatic surface, LV is 2/3. Sternocostal surface, LV is only 1/3. So understand this part. Then again a diagram over here showing us all the grooves. Now this comes as a separate question in itself. This one mainly. So I will focus mainly on this one. Interior of right atrium. Okay, here you are seeing the posterior smooth part and the rough part over here. But interior of the right atrium, mainly what can come as a 3-number question or a 1-number question are what are the main openings inside the right atrium? And here is a list of all the openings. So many openings, yes, so many openings. So two we already know, SVC, IVC. Two major openings. But then there is a vein of the heart, the coronary sinus. 3 major openings are these. Then there are very, very small veins, very small veins, just for the sake of the question. And the veni cauda minima. And then there is also one more heart vein or 2 more heart vein, the anterior cardiac and the right muscle. They are the veins of heart only. Right on the coronary sinus, the Thebesian or the Thespian veins and the marginal and the cardiac veins, we have these veins. Then obviously from RA to RB, we have the tricuspid opening. So all these openings, guys, this diagram is important. Try to show you, let me just use a highlighter over here. Show you the openings, few openings, coronary sinus opening over here. IVC is being opened over here. Okay. Then you have the superior vena cava going down. Then you have this tricuspid valve opening over here. Right. Then other small openings, at least writing them in the theory part, because those small venous openings can't be shown in all the diagrams. In interior right atrium, this diagram, guys, practice. This comes as a question. If they only ask to enumerate the openings, simple 1 marks or max 2 marks, write it. But if the question is more than 2 marks, try to draw the diagram over here. Okay. Interior right ventricle can also be asked. So again, some of the openings over here, ventricular part, interior right ventricle. And yeah, question can come out the walls also. So tricuspid valve having 3 valve leaflets. Practice this diagram also. Though it is not as commonly asked, but can be asked. And it is asked also. So practice this valve diagram. Let me show you one more valve, the left ventricle valve over here. So there's bicuspid valve. Okay, only 2 cusps. That was the right sided. So the most important over here is the interior of the right atrium. Then we have the valves. And then question might come of the other chambers like right ventricle, left ventricle. But mostly it is right atrium or the valves is the question that is normally asked. Okay. Fibrous skeleton of the heart can come as a question. This diagram can help you. Fibrous skeleton is basically how all the valves are actually correlated or joined to each other. A small topic, but it can come. Practice this diagram. And for just writing over here, few points consist of what? 4 fibrous rings at the base of the ventricle around the orifices. Orifices are your pulmonary orifice, aortic orifice, mitral orifice, tricuspid orifice. These are 4 basic orifices. Okay, so this fibrous skeleton, basically you have this fibrous tissue. So heart is actually all muscle. But in the center, you should have some skeleton, like our body. If you look at a human body also, it's basically major mass only. The skin, fascia, muscle, vessel, okay, superficial fascia, fat and all. But the core of the human body is a skeleton. Yes or no? Similarly, if you look at a heart, it's basically a muscle only. But the core of the heart, where all the walls are actually anchored, forms the fibrous skeleton of the heart. Okay, so do remember this point also, very small one, but do remember it. Make this diagram, and then They can be questioned in the physiology also regarding the conducting system of the heart. But anatomically, you should practice this diagram, guys. 1 or 2 star marks. And let me highlight some points over here. Begin with SA node. Then go to your AV node over here. Let me just move this a bit. AV node again lying in the where? In the interatrial groove only, or interatrial septum. So AV node lies in the interatrial septum. Then from here it will go to the AV bundle of his, then goes to both the right and left bundle branches. Okay, so after AV bundle, it goes to right and left bundle branches, goes to the respective ventricle, and try to make a moderator band over here. This moderator band is present where in the right ventricle, and it is basically a septomarginal trabecule. The more you read about the chamber basically of right ventricle, it will come there. Conducting system of the heart. And this conducting system of the heart, they can even ask you its blood supply, which we'll see in a while. The proximal supply is basically from the right coronary artery. The distal part is mainly supplied by the left coronary artery. Remember this part also. So a bit of 2-3 lines about this SA node, pacemaker, sulcus terminalis supplied by RC, as I said, that the proximal part of the conducting system by a right coronary artery. And the distal part of the conducting system is, but what is the importance is that whenever these coronary arteries are blocked, okay, myocardial infarction, all that, these SAN nodes and other AV nodes and bundle branches, they get affected, leading to heart blocks of different stages. And those different stages, heart block, first degree, second degree, third degree, and so many other complications, you will read later on in their medicine subject. But these things have to be noted right now in the first year only, no? Should know. The problem in the vessels or cholesterol accumulation, infarction, thrombosis in the coronary vessels can have heart blocks of varying degrees. Okay, just remember that. So if we have SA node, we have AV node also. It lies in the atrial septum supplied by RCA. And then we have the, oh yeah, conducting system comes, try to make this, this flow chart over here. So for a question like conducting system, it is best to make a flow chart. So SA node to AV node that we know, right? From AV node, we have going to AV bundle. Then we have the fibrous trigone, then goes to the IV septum. Now it's going from atria to ventricle. Okay, from there it goes to the muscular part of the septum into the two branches, right and left branches. And there, from there it goes to the right sided into the septomarginal trabecule. What is this? Moderator band. So make a flow chart. Then goes to the right side over here. And also later on go to the left side, left bundle branch, supplying the left ventricle. Defect in the conducting system causes arrhythmias and different stages of heart blocks that we'll study more in medicine. In a medicine subject, cardiology, CV system is a totally different, big, huge subject. And is not a subject, but a big, what we can say, a big chapter, but it is more like a small subject only, cardiology, because that is used in medicine, pediatrics, gynae, name it. Heart is used in all the subjects. There's an image over here showing us all of this. Lastly, not least, let us see a bit of coronary circulation. Basically, we have two vessels, RC and LCA. The right coronary artery and the left coronary artery, simple as that. Both are coming from where? Both are coming from the aortic sinuses. That is, both of them are coming from the ascending aorta. So they are carrying oxygenated or deoxygenated blood. But if they are coming from aorta, they should carry very good oxygenated blood. Size-wise, if you go, then LCA is bigger than RCA, size-wise. LCA is bigger than RCA. If the question comes, or not if the question will come, okay, what about the dominance of heart? Dominance of heart is governed by the right coronary artery branch, and that is posterior interventricular artery that we will see. Again, I repeat, there are two coronary arteries. There can be three also, but mainly there are two, right and left, which are coming from the beginning of the ascending aorta. Size-wise, LC is bigger than RC. Why? Because we all know that of the four chambers, RA, LA, RV, LV, which is the thickest chamber, which supplies blood to the entire body, and that is the left ventricle. Thickest, no? Thickest means myocardium is very thick. Blood pressure 120/80 from LV only. So this LCA will supply the LV. So LCA needs to have more blood inside it. So size-wise, LCA is bigger. And dominance of the heart is governed by the posterior interventricular artery, which in 90% of cases comes from the right coronary artery. Basics. Then let us see more. Two coronary arteries, bit of theory over here. There are few branches, mainly by diagram. So again, this same heart diagram, as I said in the beginning, where we used to draw that apex and base and grooves. Here you can also start to draw some of the vessels. Okay, so here we have the vessels. Here you see this is the ascending aorta, and this is the LCA, the left coronary artery, and that is the RCA, the right coronary artery. So one is anterior view is this, and let me show you one more view, that is a posterior view over here. So this is the same RCA that came from anterior and came behind, and this is your branches of LCA that is going on the left side. And let me show you one very, very important part. What is that? You can see this RCA that goes down and down and down. This is the posterior interventricular artery. And as 90% of cases, it is a branch of RCA. So we call heart as normally 90% of times heart is known as the right dominant heart. Okay, so in this RC and LCA, let me tell you what you have to go. You have to learn about their name of their important branches, guys. This you have to write. So diagrams, name of branches, applied part, obviously, angina, MI, all those you can write. Okay, so diagram and name of the branches are very, very important. Let me just go a bit into branches of the right coronary artery. I will urge you to take a screenshot of this. Right conus artery, anterior ventricular, atrial branches, and other posterior branches. These other posterior branches over here. Understand, but in a nutshell, let me tell you. Understand the course of the RCA. It is going from right side, going behind, circumflexing around the right border, and going back, and then goes below, forming the PIV over here, on the posterior interventricular artery over here, and that forms this right coronary dominance. And as it is passing mainly between RV and RA, it mainly supplies RV and RA. Remember that. Okay, LCA, here you can see LCA branches, circumflex artery, branches over here, atrial branches, left marginal artery over here, some of the ventricular branches over here, and other anti-interventricular artery is very famous, known as LAD, that is left anterior descending artery. So branches of these vessels, you have to draw and name them. Simple as that. An applied part, you can talk of the angiograms, you can talk of so many things, anginas, the MIs, the pain, the thrombosis, the embolism, and all that. Okay, so yeah, heart arteries are important over here. Coronary arteries, what part do they supply? Take a screenshot of this particular slide as well. Will help you in your exam writing. Branches is one thing. That what are the branches of RC is one thing. In what areas does it supply is another thing. And they are both correlated. But in the exam, only you have to write in the form of different topics. No? That it will obviously supply the RV and RA, as I said already, because it is on the right side. It will also supply other areas like SA nodes and AV nodes over here. And look at the LC, what does it supply? Mainly the LV over here and most of the LA over here. Left side. I hope the point is clear. Okay, venous drainage, you have the coronary sinus. Do remember the coronary sinus. This is coronary sinus over here. And where does it open? Into the right atrium, because opening, it is one of the openings of the right atrium. It is one of the openings of right atrium, if you remember clearly. Okay, guys, so this was all about. I'm not going into more details of the, because this is a separate in itself a big topic. I just told you what are the important points that you have to cover up while discussing the heart and the coronary vessels. Okay, just let me see an empty slide over here. 1 second, yeah. So today, understand to revise your mediastinum, how to divide it and the contents of it. What are the basic diagrams that you do write in heart? Apex, base, surface, border, grooves, all of that. Then the coronary artery is very, very important because heart attack is very common, we all know. And then in the beginning, as we discussed the diaphragm, all the openings, major, minor, both. And as I guess we also begin with the zygous system. So yes, this is very, very important. So 5-6 topics in an hour, I guess sufficient. More than that will be more of a burden for you guys. Okay, so revise it. Let me know any queries if you have. And I guess that's all for the thorax part. revision this much is enough. Rest is up to you for your own hard work and the revision. Next, I guess we can have a small session on any queries. I urge all of you also who are going through us regularly, in the comment box, write your queries. So tomorrow or next session, we can have a query session along with some topics of genetics if we might touch on it. But I would ask you, if you have any genuine queries which you are not understanding, any of the topics which your university is asking you repeatedly, and you are facing trouble in that, you can ask us directly or indirectly through the comment box and all, so that we can devote our time in the next session. Because our main motive of all these sessions that your queries are sorted out. So they only will be sorted out by you asking them in the first hand. We are trying our best from our side, but if there is any other query, do reach out and ask so that we can try to sort it out. Okay, so that's all from my side, guys. I hope you enjoyed the session. All the best with the practicing of diagrams. Anatomy diagram is very important. See you guys. Bye bye. Take care.